All right, good evening, colleagues, and all the people who have joined us tonight for this public lecture. It is really a pleasure for me to welcome you to this lecture on behalf of the university management. As you're all aware, this lecture will be delivered by none other than Professor Salim Abdool Karim. And if you look at this, you'll agree with me that it is quite an opportune time for us to be engaging on issues of this nature. Health generally is quite an important issue. All of us are concerned about this or that aspect of our health. And it becomes very important for us as human beings to engage in discourse of this nature, to look at issues of health. How do we deal with them? How do we prevent them? How do we really manage them, depending on the nature of challenges that we're faced with in our lives? So it is really a pleasure for us to be welcoming Professor Karim to this public lecture to engage with us on this particular issue. With that in mind, I want to also say that we are encouraged, all of us who are in this platform, to really engage with the issues that he's going to raise, to engage with him, ask questions, make comments, because it's only when we engage in this nature that we enhance our understanding of issues and possible solutions that we might want to put in place in dealing with challenges that we encounter in our societies and in our lives. But that before I call Prof. Salim to deliver the lecture, who is Prof. Salim Abdool Karim? Prof. Salim is the director of the Center for AIDS Program of Research in Southern Africa, which is known as CAPRISA. He's also the professor of global health at Columbia University in New York. He serves as a special advisor on pandemics to the Director General of the World Health Organization. He is an adjunct professor of immunology and infectious diseases at Harvard University. He is an adjunct professor of medicine at Cornell University as well. Furthermore, he is Pro-Vice Chancellor for Research at the University of KwaZulu-Natal. He is a member of the WHO Science Council and Vice President of the International Science Council. He is a member of the U.S. National Academy of Medicine and a fellow of the Royal Society. This is not even a fraction of his credentials, but we thought in the interest of time, this is what we're going to share with you, just to give you a sense of who Professor Karim is. What we are going to experience right now is that all of us on the platform, our mics have been disabled. So if you want to make comments to us during the lecture or to alert us of something, you're allowed to put notes on the chat box. Once the lecture is done, you will be given an opportunity to engage with Prof on issues that you would have raised. You are encouraged to raise your hands so that we are able to engage with the issues that you will have raised. So with that said, and without wasting any more time, I'm going to invite Professor Salim Abdool Karim to deliver the lecture. Prof, it's over to you.
Thank you very much. It's indeed a great pleasure and an honor for me to be here with you this afternoon and to give a talk on a topic I originally offered of talking about the tale of two pandemics. But of course, since I gave that topic forward, we're now in the midst of the potential threat of a third pandemic that I'm involved with. So I'm going to touch on Mpox briefly towards the end of my presentation. So I'm going to concentrate now on pandemic 1. And I'm going to share with you a 30-year journey focused on one key challenge in the AIDS epidemic, and that's preventing HIV in young women. Now, most of the articles I will share with you are articles that I've published, and most of it is articles that I've published jointly with my wife. And it needs to be made clear that when I publish something with her, she's probably done most of the work. I'm just claiming a lot of the credit, but actually it's mostly her work. So let's go directly to AIDS. So what do we know about the current situation globally on HIV? Well, there's about 40 million people living with HIV. Last year, there were 630,000 deaths and 1.3 million new infections. That translates to just over 3,500 new infections each day. Sub-Saharan Africa contributes about 50% of the global burden of HIV. And South Africa, if you just look at our own situation here, 1 in every 5 people living with HIV in the world lives here in South Africa. And that the bulk of the infections that are occurring in Africa are in young women. Young women bear the brunt of the HIV epidemic in Africa. So this is not new. When we came back to South Africa, having completed our master's degrees in Columbia University in 1989, we undertook this study. And we showed with this study back in 1990, where all the talk was about HIV in men who have sex with men, we did a study in the community to look at HIV. And what we found was this incredible diagram. And I remember the first time I saw it, I sat back and I said, wow, I would not have expected this. So what was unusual about it is that if you look at the 10 to 14-year-olds, in both boys in the blue line and girls in the red line, there's very little HIV, as you would expect. But look at teenagers, 15 to 19 years old. Among the boys, very little HIV. But among the girls, you're seeing close to the peak of their prevalence. Now, it doesn't take, a student at Sefako Kato University to, realize or work out that these girls in the 15 to 19 age group, these teenage girls, are not getting HIV from these boys. They are getting it from men who are about 10 years older. And indeed, this age disparate sex became a critical issue in understanding the dynamics of HIV in Africa. And this was in one of the very earliest, one of the first ever community-based surveys of HIV in Africa. Remember, we're talking now about a study done some 34 years ago. And if you look at since then, studies have been done in many countries in sub-Saharan Africa. And if you look at the prevalence of HIV in 15 to 24-year-olds, the red bars show the prevalence in women, and the blue bars, the prevalence in men. And you can see country after country, the red bars are much higher than the blue bars. Whether you look at Kenya, Central African Republic, doesn't matter. All of these countries, the red bar is substantially higher. So, looking at that, we wanted to get a better understanding of that. And several years later, Curation undertook this study. She looked at high school students. These are students in grades 9 and 10 in one district in KwaZulu-Natal. And she looked at the prevalence of HIV in the boys and girls. So if you look at the boys, you can see that the prevalence in the boys ranged from about 1% in the youngest to around 1.8% in the oldest. So the prevalence rate in the region of 1 to 2%. If you look at the situation now in girls, drastically different. I mean, already by age 15, 2.6% of the girls were HIV positive. I mean, that translates, to literally 1 in 40 or so. If you're looking at by the age of 20, 1 in 4 girls in these schools, in these high schools, was HIV positive. That was quite telling for us. And we needed to understand that we have to do something to change this situation if we're going to make an impact on HIV in Africa. So we did a large community-based survey. Again, this was roughly about 25 years since the previous one. So it was done in around 2016. And in this particular community, again, it's in one rural district in KwaZulu-Natal. It's a large study, nearly 10,000 people. You can see in the red bars the way the prevalence of HIV goes up. In fact, when you get to women who are in the age group 31 to 32, it's more than 2 out of 3 women are HIV positive. So we are dealing with incredibly high prevalence rates of HIV in these women. So in 2016, when we did that study, we sequenced the viruses. We sequenced thousands of viruses, and we used those genetic sequences to understand who was infected with a similar or the same virus as someone else. So we could cluster these viruses based on their genetic code. And what we found when we looked at that kind of sequencing and phylogenetics, we can track who is infecting who. And put very simply, we unraveled this cycle of HIV transmission. So what is the cycle of HIV transmission? Cycle of HIV transmission shows that these young women below the age of 25 years, that they have a very high rate of infection. And that by the time they reach the 30s, their prevalence of HIV is quite high, as you saw, around 60%. These women in their 30s are having sex with men in their 30s. These men are acquiring HIV from these women, and the age difference is about 1.1 years. So in other words, roughly these women, by the age of around 30, they are now finding their partners, their husbands, and they are then in that process, because of their high prevalence of HIV, are infecting these men. These men acquire HIV. They don't know they have HIV because it's a silent infection. And 39% of these men in their 30s are also linked to a young woman. These men are being linked to a teenage girl with a difference of around 8.7 years or 9 years. So what do we understand in this cycle of transmission? Men in their 30s are infecting these teenage girls. These teenage girls, therefore, have a high rate of infection and have a high prevalence by the time they reach their 30s. When they reach their 30s, they infect the next group of men in their 30s. These men infect the next group of teenagers, and so the cycle continues. So that cycle was the main explanation that we could find for the high rate of HIV in these young girls. So when we described this in the Lancet, and we provided this very nice detailed diagram in our paper in the Lancet, within a matter of months, the UNAIDS produced this report, calling this report entitled Get on the Fast Track, the Life Cycle Approach to HIV. And this report is pretty much based on this study. It draws on the evidence, the phylogenetic evidence we provided. And what they did was they took our very nice, complicated diagram and they made it very nice and simple. So it just shows that these young girls, when they grow up, they have high rates of infection. They infect men, the men infect the next generation of young girls, and so on. And that's how the cycle continued. This report, when it was released, was adopted and impacted policy in several countries. If you just look at South Africa, in our South African National Strategic Plan, you can see here how the strategic plan, their number one objective in the plan is to break the cycle of transmission. And what they did was they took the UNAIDS diagram and they simplified it. They changed the colors. They called it infection pathway. They made it their own diagram. And it's now the principal goal of South Africa's AIDS control plan. So now I'm wondering why we even bother making these very complicated diagrams when it actually can be just a very simple, easy to read diagram. So knowing that we have these high rates of infection in young women, we knew this back in 1990, we were struggling with, so what do we tell these young women? A young woman coming to me in the clinic saying, I want to I don't want to get HIV. What advice can I give her? Well, I can only advise her about the ABCs at the time, telling her about abstinence, behavior, to be faithful. But she can be faithful, but the very man she's having might be the one giving her HIV. Condoms, and of course, condoms are under the control of men, and circumcision is a male prevention. So there was literally nothing that we had. We had no tool that we could provide young women to protect themselves. And that was very well captured by Zina Stein in this commentary in the American Journal of Public Health. So we set on this path. We're looking at, from that very early study in 1990, this blue line reflects the prevalence of HIV in pregnant women in South Africa. So we started trying to develop different techniques. So very early on, we used a spermicide called nanoxynol 9, and we tried to make a film of it. And we tried in our labs in Durban, and we didn't succeed. But there was a company in the US that could put the nanoxynol 9 onto a film for us. And so they did it for us and sent it back to Durban. And we did a study of nanoxynol 9 film in sex workers, and pretty much, didn't really produce the results we wanted to see. But at that time, the WHO was developing a nanoxynol 9 gel. And so we joined their study. And their study showed similarly, nanoxynol 9 doesn't work. And so we changed tactics. We changed to polyanions. We looked at different products. We looked at Pro 2000 gel. We looked at Buckwood gel. We looked at a range of different kinds of approaches. And basically, all of it failed. For 18 years, all we did was fail. In fact, at one stage, we were even known as experts in failure because we were that good at it. We'd done it so many times until 2010, when we finally achieved success. This was with a drug called tenofovir. We managed to get some tenofovir from the drug company Gilead, and we made a gel with it. And we worked with another different company in the US that had expertise in making these gels. We worked with them, we made this gel, we did the study, and we showed that tenofovir gel protects against HIV. It reduces the incidence rate of HIV in women. And overall, it wasn't a very impressive result at 39% protection. But in those women who had high adherence to the gel, protection was significantly higher. So when we presented these results at the International AIDS Conference in 2010, it was a game changer. It was Lancet's Paper of the Year in 2010. In the journal Science, it was ranked among the top 10 scientific breakthroughs. There were editorials in the New York Times. It was covered in multiple newspapers. It was worldwide headlines. And it literally was a game changer in the field of HIV prevention. And so from our very early results, at the same time, other groups were using tenofovir, but in a tablet form. And eventually, when their results came out, they showed the tablets work even better, and it's cheaper to use the tablets. So we worked with the WHO, and eventually the WHO released a guidance in 2015 to recommend tenofovir-based tablets as oral pre-exposure prophylaxis, or what we today know as PrEP. The South African government implemented PrEP in 2017 in a program that rolled out Truvada as pre-exposure prophylaxis. So when you look at all of that and trying to understand how can we do better with tenofovir and tenofovir gel, and so we analyzed the amount of tenofovir concentrations in the vagina, in the genital tract, and we showed actually if you have high levels of tenofovir in the genital tract, you have incredibly good protection. The protection levels exceeding well over 70%. So we knew that what was critical was to get high enough tenofovir levels in the genital tract. And of course, nowadays, you might have heard most recently about 2 months ago, the same company, Gilead, using another drug that they developed called lenacapavir, that they showed that lenacapavir is 100% protective in young women who are against HIV. It does better than Truvada, it does better than tenofovir, and this drug is now, we're just waiting for it to get licensed, and this is a 6-monthly injectable. So it gets away from the challenges of adherence and provides us with a very powerful new tool that we could be using to protect young women from HIV. So while all of this is going on, we discovered in 2012, we discovered a young woman in one of our studies had a very powerful antibody. Now, anybody who gets HIV develops antibodies. But when you develop an antibody, when you get infected, that antibody will only kill the virus that infected you. It's what is called a strain-specific antibody. So HIV has so much of diversity that if you had to test somebody's antibodies against a panel of, say, 400 antibodies, which is what we did, you will find that it'll only kill 1 or maybe 2 of those viruses because it's highly strain-specific. So that was a challenge because we know these antibodies don't really work against a wide range of HIV. But in 2010, 2 groups in the US discovered that there are rare individuals that make something called broadly neutralizing antibodies. They make antibodies that don't just kill 1 or 2, that these antibodies can kill a wide range of HIV. And so we discovered one such woman, and her antibody turned out to be a highly potent antibody. So we took this antibody and we made the first 3 grams. It took us 7 months to do that in the lab. And we sent it to our colleague, Dan Baruch at Harvard, and he put it in the monkeys. And when he put it in the monkeys, we found amazing results. So the first was that what we did have in this particular antibody, this what is today, we call it CAP256. So this is Caprisa 256. She was the 256th person we enrolled in a Caprisa study. So when we compared her antibody against a wide range of other antibodies, we found that she had this incredible potency, very high potency with pretty good breadth. Now, when you look at what that does in monkeys, it was striking. So what Dan Baruch did is that in the control monkeys, he gave them a placebo, but it's a blinded trial. So he doesn't know which monkeys received placebo and which monkeys received Caprisa 256. In the placebo monkeys, every one of the monkeys that received placebo got infected. And this is through a challenge with a monkey form of HIV. The monkeys that had Caprisa 256, not one became infected. In fact, to this day, we have not been able to infect a monkey that has received Caprisa 256. And even if we give them really low doses, we still don't see breakthrough infection. So we see very good protection in monkeys from Caprisa 256. So we then made batches at the NIH, and they shipped it to us here in South Africa, and we then put it into humans, and we've shown that these antibodies are pretty safe in humans, and they have a pretty good half-life, and they work at therapeutic levels roughly for about 6 months. So now we have the potential to use this antibody to protect young women by giving them a 6-monthly injectable. So the question is, so it works in monkeys, does it work in humans? Well, sorry to tell you, don't have the answer yet. We've just enrolled and we are in follow-up, just over 1,000 women in a study. So watch this space to find out whether CAP256 actually works. So if you think about it, this long journey that we've been through, where from the time we discovered Caprisa 256, and when we enrolled her in 2004, when she became infected, we put her on treatment. And in 2012, when we discovered her broadly neutralizing antibody, and we were then able to isolate it and manufacture it and then put it into trials. And then we started the phase 2 trials 2 years ago. It's a long, long journey, but it shows you how we can start with a patient in a clinic and find an antibody, develop it, and use it as a potential therapeutic in our own setting. This is about innovation. It's about taking the opportunities that we see to manufacture completely new potential therapeutics for HIV prevention. At the same time, we started working with another group in Los Angeles. And this group took the same drug, tenofovir, but took a different formulation of tenofovir alafenamide, and they micro-tableted it, and they put it in a matchstick size tube of silicone, and what we call an implant. And we take this implant and we insert it under the skin on the arms of women, and we're looking at how well does it release tenofovir so that we get some idea of whether we can achieve therapeutic levels of TAF. And so far in the study, which is still very early in a phase 1 study, we found that we're not getting the kind of consistent release we'd like to see. So we're a bit back to the drawing board in terms of trying to make a better implant, because if we can make this implant, we can basically put it in under the skin of women for a whole year, and they don't need to worry about whether they will get HIV. It can protect them in that way. So the whole idea being, can we make something that works over a long period to protect young women so they don't get HIV? Okay, so that's the story of HIV. Let me now go on to the second pandemic, which is COVID-19, and tell you about a 3-year journey on just one key challenge, and that's the SARS-CoV-2 variants. So very early on in May of 2020, I worked with the Ministerial Advisory Committee in the Office of the President and the Minister's Office in developing an approach that we could take to responding to COVID-19. And we described this 8-stage response as an overarching approach to how to deal with this pandemic, and published it in the New England Journal of Medicine, and several other countries have borrowed parts of it, if not all. But shortly thereafter, we highlighted in this article in Science about how COVID-19 was impacting TB and HIV care. We saw a drastic reduction in patients getting viral loads and CD4 counts and HIV and doing TB testing. And this impact, of course, has a huge set of repercussions on the control of these two infections. But it was at the end of 2020 when Professor De Oliveira and I discovered the challenges of dealing with new variants. So here we provided in the New England Journal of Medicine, one of the very early informations about the importance of these variants. We provided some clinical data, some public health data, and some data on neutralization, and what it means for vaccines to have these different variants. And at that stage, we were dealing with the alpha, beta, and gamma variants. And we showed that these variants actually have an impact on vaccine efficacy. So this became quite a critical issue because, until these variants emerged, we were dealing with a situation where we had a virus on the one hand, we had a vaccine on the other hand. All we needed to do was vaccinate people, and that would be the end of the problem. But of course, that's no longer the case because these variants can escape the vaccines. And so we began to address this challenge of the variants, published several articles in The Lancet, understanding how we can look at future scenarios. So if you look at one of the big responsibilities that fell on our shoulders, it was to provide science advice to several governments. At one stage, I was advising over 24 different governments. And here on the left-hand side, I'm briefing the US government, and this is the US Congress, Committee on Science and Technology. And on the right-hand side, I briefed the UK Parliamentary Group on COVID-19. So providing that kind of evidence was critical because it enabled countries to learn from our experience about what we had learned from these different variants. So let me go to Mpox. So Mpox is part of the smallpox family. It causes these skin eruptions, these little lesions, and the virus is teeming in these lesions. It's a very slow spreading virus, so we don't really worry too much about it. It's not spread through the respiratory route. And we've had many outbreaks of mpox, and usually as zoonoses. They come from animals into humans, and we just get a few cases. Usually it peters out. So the situation a few months ago changed. The situation was different. So what was different about mpox? Well, the first is that we were now seeing a drastic increase in the number of cases. So the overall burden of new cases of mpox was quite significant. We had what we have in this year, we have about 3 times more cases than we had when the first public health emergency of mpox was declared in 2022. And that was quite concerning. Not only did we have a lot of cases, but the cases were increasing. So why was that? Why were the cases increasing? Well, it's increasing because we have a new clade of the virus, clade 1b. And this clade emerged in the mining region of the DRC. And this particular clade, what we have found with this clade is that it is changing. It's spreading in a different way. And we think that there's now good evidence to suggest that this new clade is not merely spreading through close contact, it's also spreading through sexual transmission. And that became particularly evident in this piece in Lancet Infectious Diseases, where if you look at the cases of mpox with this new clade, the clade 1b, what you see is that a large proportion of those who were infected were sex workers. And of course, because you got a problem with sex workers getting infected, they then pass it on to their clients. And that was a big concern to us because we've seen how a sexually transmitted infection can spread quite rapidly in Africa. So this heterosexual transmission of this new clade was quite a big concern for us. And so the Africa CDC has an emergency consultative committee. It comprises 20 scientists from throughout Africa. And our job, I chair this committee, our job is to review the available data and to provide a recommendation to the Director General of the Africa CDC on whether he should declare a public health emergency. And so in the middle of August this year, we reviewed the data. We looked at all of the available evidence, and what we found is that, well, there's certainly certain challenges and limitations in the data because the reporting is inadequate. But what we found is despite the underreporting, that there was a high burden of cases, much higher than we've seen before. And the cases were increasing with this upward trend, and the case fatality rate running at around 3 to 4% was significantly higher than what we've seen from mpox previously. So while the previous clade 2 outbreak of mpox in 2022 had a case fatality rate of less than 1%, we were now seeing a much higher case fatality rate, and that was quite concerning. So we have a lot of cases, the cases are going up, and the death rate is much higher than we've seen before. And then the final concern was that this new clade 1b, was now spreading to other countries. 3 additional countries have now reported cases of clade 1b mpox, countries that hadn't had mpox before. And of course, now we know, there have been imported cases in Sweden, in Thailand, and it's just a matter of time before we see imported cases of clade 1b mpox into many other countries. And of course, it has huge potential to spread in the rest of Africa, given that it's now spread through sexual transmission. And so we recommended the declaration of a public health emergency of continental security. The very next day, the Director General of the Africa CDC called a press conference and made an announcement and declared the public health emergency. And the whole idea behind it is to mobilize resources, get better coordination, and to get down to brass tacks. We can bring mpox under control. We just got to focus on the case detection, the contact tracing, and then when we have vaccines, to do ring vaccination. And we can bring this under control and avoid further spread and try and limit the spread of this virus within the DRC before it becomes a global pandemic. So let me end off with, what's the key lesson that we've learned from all of these pandemics, and what can we take into the future? And so this is the key lesson I'd like to share with you. And it's a lesson that we've seen from HIV for COVID-19, and that's the importance of mutual interdependence and shared responsibility. In that, and I'd like to quote here from a report, a UNAIDS report, and this report is entitled, "How AIDS Changed Everything." And I quote, "The AIDS movement has demonstrated that the AIDS movement demonstrates that with a shared vision, shared responsibility, and through global solidarity, we can change the course of history." We can change the course of history, and we have, through global solidarity, where wealthy countries are providing funds to the Global Fund and to PEPFAR, and that these funds are making treatment available in the most remote village in Africa, that no one needs to die of HIV anymore because treatment is available, reflects our global solidarity. That we look at this pandemic as a problem that belongs to all of us. And if we do that, we will truly appreciate that in dealing with any of these pandemics, we've got to look at them as a global problem requiring a global solution, because no one is safe until everyone is safe. Thank you very much.
Thank you very much, Prof, for such an encouraging and very interesting presentation on this particular topic. I think one of the things that I want to just highlight was people on the platform are preparing their questions and comments. Your last statement, which says no one is safe until all of us are safe, is something that I think stands out and something that we should embrace going forward. So one thing that I just want to say as we prepare for our questions and comments is that the manner in which you presented this lecture, Prof, is such that even those of us who are not in the medical space can actually follow the issues that are very complicated, because you did that in such a simplified manner. And for that, we're really appreciative of your presentation, Prof. With that said, I'm going to open the platform for questions or comments. So in the interest of time and to make sure that we accommodate as many people as possible, please make sure that your comments and questions are as brief as possible. All the people on the platform have been muted. So if you want to raise a question or comment, please raise your hand and then we will acknowledge you and then we'll take it from there. Any questions, any comments from the floor? If you're struggling with your mic for whatever reason, you can just raise your voice and ask your questions or make a comment. Alternatively, you can put your questions or comments on the chat box. We will attend to them accordingly as well. We've got Matilda on the platform. Matilda, you can ask your question or comment.
Yes, good evening, colleagues, and thank you, Prof, for the presentation. We've worked together through COVID in the ministerial committees, Prof. And today, integrating the whole history of HIV, COVID, and Mpox, brings a new hunger in me, but this hunger is mainly also for the community. As Kenneth says, this lecture would benefit a bigger community forum if we knew. I thought this is academic, is a serious scientific lecture, and you made it so consumable, and we need these platforms to really demystify science, to demystify clinical trials, to share this depth in an easy format with our communities. And I would appeal that if this lecture is going somewhere again, we would be invited again, and we would be encouraged to invite our community partners, where we will be implementing our science as we work within communities. And thank you very much. I've learned again, even better today, Prof. Thank you. Thanks.
Nice to see you, Matilda.
Thank you for the question. We've got Cheza on the platform. Please take on. You can ask a question or comment.
Yes, good evening, everyone. I just hope that I'm audible. According to the presentation that was this thing presented to us by Prof, in the beginning, with regards to HIV, you told that you displayed data that tells us of the age differences of sexual partner or of this thing, of the transmitters and receivers of AIDS, And to a degree, we can say that most people who are transmitters of AIDS are in fact knowledgeable know their status very well, but choose not to disclose and only disclose once their partner is affected. Do you think legislation that declares or instructs people that mandates that people should know their HIV status and declare to their partners during sexual intercourse or in ever contact would be important in meeting or this thing, flattening the increased trend of what you call this new transmissions. Would you think it would be effective, and would you advise on such?
The question you've asked is one that we have addressed in various fora and has been debated quite extensively. What is the role of a legal approach? Can we criminalize the transmission of HIV and use that as a mechanism, as a disincentive? And some countries have, but it has had almost no impact. So the big challenge you have is that when somebody gets HIV, they don't know that they have HIV. And it's not like they have symptoms or something that they could have worked it out. So the transmissions often occur before they know they have HIV. But even if they knew they had HIV, to criminalize it will be incredibly difficult, and probably will be so much after the fact that probably have little impact. So as a public health measure, no, not the wisest strategy. From a cost point of view, the complexity of dealing with this through the courts because it'll take years to deal with in the courts, is really not going to achieve much. So I think what we have to do is focus on the public health approach. We know how to prevent HIV. We know that case identification is important because we can put patients on treatment. They're not on treatment, they're HIV negative, we can offer them PrEP. And so we have the tools. We don't need a legislative tool. We don't need a criminal tool to add to our armamentarium at this point. So I wouldn't recommend it.
Thank you very much, Prof. We've got Stelo and Ola on the platform. You can take your questions in that order, colleagues.
Thank you, Prof, for the informative presentation. Just one quick one. When it comes to the Mpox one, do you think as a country, South Africa, we are ready in case we can have that we can be exposed to such virus like the way COVID dealt with us? Are we ready as a country at the moment in terms of now? Do we have enough facts about the virus, and in terms of now being prepared, resources-wise, like are we ready as a country, or we have to wait for the virus to have for us to have a lot of cases before we can start acting? Is the government having talks when it comes to that thing in case of readiness? Thank you.
South Africa as a whole is pretty well prepared for Mpox. I mean, we actually went through preparations during the 2022 public health emergency. So we have the capabilities, we have the diagnostic capabilities, the contact tracing capabilities. We have most of the capabilities. The one thing we don't have vaccines. And that's a problem because you can't actually get the vaccines. There's so few vaccines available. It's only manufactured by 3 companies, and they have very little stock. So, South Africa perhaps needs to contemplate whether, it needs to fund an initiative to make our own vaccines. It's not hard to make a vaccine against Mpox because it's a vaccinia virus. So how serious a threat is it to South Africa? Well, everybody who is over the age of 40 does not need to be concerned about Mpox. So, Professor Sibaya, Professor Mahotle, and people like myself, we're not concerned. And the reason we're not concerned is because we had smallpox vaccination. Smallpox vaccination, which was stopped in the 1970s, means that as somebody who's received smallpox vaccine, we are immune to Mpox. So we have no concern. So it's the younger population that is we have a concern about, and that's where it could potentially spread. In South Africa, we have a sizable population that is below 40. And so part of being better prepared would be to look at making vaccines available to that population. And that would be a good thing to do, if we can find an affordable vaccine. Right now, the vaccines are not affordable. They are between $100 and $200 a dose, which is very expensive. They're very effective, but really very expensive. And so I think that when a cheap vaccine becomes available, we would be in a better position to vaccinate the population below 40, and that way protect our entire population from Mpox.
Thank you very much, Prof. We've got 2 people on the platform, Jacob and Mngedisi, in that order, please.
Thank you, Prof, for the good presentation, and we have learned a lot today. And I'm glad that you have touched on the vaccine in relation to Mpox. But in one of your teachings, in one of the publications, you taught us that designing a successful vaccine against HIV has been hampered by the lack of immune correlate of protection. And therefore, I just want to find out from you, but you have just gave an update in relation to the vaccine. CAP 56, is it a future vaccine that we can rely on in terms of vaccination in terms of HIV?
So that's a very good question. Whereby giving somebody CAP 256, we're actually providing passive immunization. So we actually, instead of giving you an immunogen, so you make the antibody yourself, we just give you the antibody. So it's a passive. We use that, for example, ZIG, zoster immunoglobulin is passive immunization. So the passive immunization, has, based on what we learned from the clinical trials, has potential to protect against HIV. The problem is that if we wanted to make it a vaccine, that would be incredibly difficult because we don't really have the technology to do that. So there are two groups right now in the US that are trying to get humans to make broadly neutralizing antibodies. That's a tall order. That's going to take a long time because it's very difficult. To get broadly neutralizing antibodies, you have to go through multiple immunogenic steps. You got to get the right B cells. You got to what we call germline targeting. We've got to target the right kind of B cells. We've got to stimulate them to make the right antibodies. We've got to then polish those antibodies over time. We've got to get, it's a very difficult task. So we are not anywhere near a vaccine against HIV. I mean, there's no candidate out there that looks promising, anything of that sort. It's going to take us a while. But in the meantime, with amazing results that we've seen from lenacapavir, from the terrific results we know we get from treatment, we already know how we can bring HIV under control. We actually don't need a vaccine to do that. It'd be nice to have a vaccine. A vaccine is always very helpful. But in the absence of a vaccine, there is still quite a bit that we can do. And so that's what our whole global strategy is about, that working with UNAIDS, our global strategy is to use treatment and use PrEP as a mechanism to bring the incidence of HIV down and to try and bring it under control. And we can do so, even though we don't have a vaccine.
Thank you very much, Prof. Ndedisi.
All right. Good evening, Prof. Good evening, colleagues. So my question is on HIV and COVID-19, and I'm not sure if you touched on it earlier because I joined a bit late. So earlier in the start of the COVID-19 pandemic, it was realized that the immune compromised are at higher risk of severe COVID. But when the pandemic reached Africa, it wasn't as bad as people expected it to be, given our high HIV incidence rate prevalence. So I just wanted to find out from Prof, what is the immunological basis of this phenomenon? Why were we not that I wanted it to be this way, but why were we not severely affected by COVID-19, given our HIV populations?
Yeah, so that's a good question. I've been asked that question many times, and the short answer is I don't know the answer. But what we do know is that the mortality rate, or what we call the case fatality rate from COVID in South Africa, was pretty comparable to what was seen in other countries. So South Africa didn't get off lightly. We had perhaps fewer cases than we should have, but the mortality rate was comparable. So it wasn't that COVID was any less severe in our setting. And in fact, most people know somebody who died of COVID, either a family member or a neighbor or friend or somebody at work. So it has taken its toll. But there are countries in Africa that seem to have been less affected. they don't have those high mortality rates. And frankly, I just don't know why. Some have argued that they've encountered, this kind of adenovirus before, or another kind of similar virus that gives them cross protection. We looked and we couldn't find any such cross protection. So there's been no evidence to guide us as to why some countries have had COVID-19 less severe, while others have had it much more severe.
Thank you very much, Prof. We do not have any more questions on the platform, but there is one that we received on the chat group from Muhora Malibacha. It says, thank you for the presentation, Prof. What were some of the lessons learned when it comes to emergency response and preparedness during COVID-19 pandemic and relating it to mpox as well? Maybe whilst at it, if you can just give us your closing remarks and observations on the discussions that we have just had tonight, Prof. Thank you.
Thank you very much. So, you've certainly picked on some of the key challenges we face in dealing with pandemics and dealing with infectious diseases. So what we have learned from COVID, we've tried to encapsulate now in the pandemic treaty. So the pandemic treaty is currently being negotiated, and the WHO is facilitating these negotiations. And unfortunately, I have to say that I don't think we have learned the lessons of COVID-19. So the original version of the treaty actually had, I thought, a superb section on the sharing of vaccines and treatments and diagnostics. Basically said that should a country develop a vaccine to a new pandemic, that 50% of what they make, they will share, that they will make it available to WHO to then distribute across the world to others. 50% they could keep and use in their own country. So I thought that was a very fair mechanism for sharing. The problem is that countries like Germany and so on just refused. They will not accept that. And the underlying issue is that they are really protecting their pharmaceutical industry. I mean, let's be clear here. The company that made the most money in COVID-19 from vaccines was a company called BioNTech. They made the Pfizer vaccine. So, I mean, Pfizer didn't actually make the vaccine. Pfizer distributed it under their title, but BioNTech makes the vaccine. And BioNTech is based in Germany. It's a German company. So they are protecting these companies. They are putting profit ahead of people. They are putting profit ahead of lives. And that's something we've got to take a stand against. Because if we don't, then when the next pandemic comes around, we will once again not have access to vaccines. And that's not acceptable, because you can't fight a pandemic in one country. It affects all countries. And if you fight it in one country and you try and bring it under control, it'll get back out of control, once the people from other countries come inside there. So it's not something you can really control in that way. You've got to take a global approach. And so for me, that has been a key lesson. It's been that we've got to understand that we've got to work together, that we can't be bickering amongst us as countries. We can't be trying to undermine each other. We can't be selfish. We've got to work together, and we've got to find a way to share, and we've got to find a way to deal with these problems as a global problem. And if we do that, I think that the next pandemic could be one that we could bring quite quickly under control. So on that note, I thank you for this opportunity and bid you all a good evening.
Thank you very much, Prof, for your remarks, final remarks, and the delivery of the lecture. As we come to the end of this lecture, I want to just make a couple of remarks drawing from the lecture that Prof. Karim has just given to us tonight. Firstly, one of the things that I take home with is mutual interdependence and shared responsibility as one of the critical things that we need to embrace to change the course of our world and the way in which we respond to pandemics. Secondly, you talked about global solidarity as one of the things that we need to take to heart as well. And finally, this is really my favorite, Prof. No one is safe until all of us are safe. And I think this is something that we should take when it comes to pandemics, and I suppose it's applicable to all phases of our lives. So with that said, I really want to take this opportunity on behalf of the University Management to thank you, Prof, for taking time to be with us tonight, to share your wisdom, to share your experience, and really to guide us in this very critical discussion that we've just had. I also want to take this opportunity to thank the colleagues, friends, and all the people who heeded this invitation to join us this evening for this critical discussion. I'm convinced that as we part ways tonight, this is not going to be the end of the discussion, but rather the beginning of further discussions around these issues and many more related to what we have talked about tonight. With that said, I want to take this opportunity to say good night. Usiku wabudi. Nda.